Welcome back to the deep dive. Today, we are grappling with something really central to medicine, I think. It's this tension, this sort of surprising contrast we see in the 21st century.
You mean between all the high-tech stuff and, well, the basics?
Exactly. Between the incredible technological progress, genetics, AI, you name it, and the very simple, very human need for, well, touch, for connection.
And that tension, it feels like it's growing, doesn't it? We're in this era. I mean, artificial intelligence can crunch these enormous data sets. Genetic sequencing is almost routine now. Molecular biology is moving at lightning speed.
Right.
And yet, the actual human experience of being ill,
Yeah.
the pain, the fear, the feeling of vulnerability, that hasn't really changed much, has it? Not since forever, really.
No, it hasn't. And it's striking. You look at patient satisfaction surveys, even with all these amazing tools, the complaints often come down to something really fundamental. Feeling rushed or unseen or just like a number in the system. And you hear it again and again. My doctor never touched me or they never laid a hand on me. It's about that connection, that ritual, maybe. The human examination that technology just can't seem to replicate.
That's precisely the point.
Yeah.
And that's why we're diving into a really key section of Harrison's principles of internal medicine today. It's pretty much the Bible for internal medicine.
It really is.
And this section makes a powerful scientific case for why the physical examination, the PE, is still absolutely necessary. Why it has this enduring role. Even now, it argues it's not just, tradition. It's a quantitatively vital tool.
Okay, so let's unpack that. Our mission for this deep dive is to get into the 5 pillars Harrison's lays out to support the PE. It covers everything from like the history to diagnosis, the hard data, and even the patient experience side of things.
Right.
But maybe we should start with the history because, for a long time, doctors couldn't really see inside the body like we can now.
That's a crucial starting point. It's easy to forget how relatively recent proper physical diagnosis is. For, centuries after Hippocrates, and he was around 460 BCE, anatomical knowledge was, surprisingly limited.
Why was that?
Mostly because of long-standing rules, prescriptions really, against dissecting human bodies. So early physicians had to rely almost entirely on what they could see on the outside and what the patient told them.
But Hippocrates himself, he was pretty observant for his time, wasn't he? Harrison's mentions him.
Oh, definitely. He was an outlier. He described clinical signs like clubbing, that swelling at the fingertips. He linked that to things like chronic lung disease or empyema, which is pus collecting in the chest cavity.
And he also described the succussion splash.
Yes. That's the sloshing sound you can sometimes hear even without a stethoscope if you gently shake a patient who has both fluid and air in their chest. Hydropneumothorax. These are purely based on listening and looking. Really quite remarkable deductions for the time.
But the real game changer, the beginning of systematic physical diagnosis, that didn't come until much later, right? Mid-18th century.
Exactly. 1761, to be precise. An Austrian physician in Vienna, Leopold Auenbrugger. This is where things really start to shift from, let's say, observation to actual examination technique.
And his story is fascinating. It wasn't some complex theory. It was practical inspiration.
Completely. It's a brilliant example of lateral thinking. He published this discovery, percussion, and the idea came directly from his father.
Who was an innkeeper.
That's right. Auenbrugger watched his dad tapping on wine casks, and he noticed his father could tell, pretty accurately, how much wine was left just by the sound the tapping made, the change in resonance.
So the sound changes depending on whether it's full of liquid or air.
Precisely.
Yeah.
And Auenbrugger had this insight. Maybe I can do the same thing on the human chest. By tapping or percussing over the lungs, over the heart, he realized he could detect things hidden inside.
Like what kinds of things?
Things like an enlarged heart cardiomegaly or fluid in that space around the lungs, a pleural effusion, things that were totally invisible before.
So Harrison's calls it the ultrasound of its day.
And it's a great analogy because it was the first sort of objective way to detect internal problems in a living person without cutting them open. His work on percussion was so thorough, honestly. Very little has fundamentally changed about the techniques in 1761.
Then the 19th century arrives, and suddenly we get this burst of new tools.
A real explosion. We go from Auenbrugger using just his hands and ears to René Laennec inventing the stethoscope in 1816. Then comes the ophthalmoscope for looking in the eye, the clinical thermometer, the reflex hammer.
And the blood pressure cuff eventually.
Right. By 1896, Rivarocci gives us the sphygmomanometer. And this whole period, say, late 19th, early 20th century, that really becomes the golden age of the clinical exam.
Why gold?
Because before widespread imaging, Diseases were almost defined by what the doctor could find at the bedside. Inspection, palpation, percussion, auscultation, these were the primary diagnostic tools. It really elevated clinical deduction.
And that brings us to Professor Joseph Bell in Edinburgh, the real-life Sherlock Holmes.
He's the perfect embodiment of that era's potential. His student, Arthur Conan Doyle, was so impressed by his inferential skills that Holmes was modeled directly on him. The stories about Bell's clinical gaze are just incredible.
Harrison's recounts one specific case, doesn't it?
It does, and it illustrates the point perfectly. A woman comes in with her child. Bell greets her and immediately asks, "What sort of crossing did you have from Burnt Island?" She says it was fine.
Okay, specific location.
Then he asks if she enjoyed her walk up Inverleith Row, and finally, was she still working at the linoleum factory?
And she confirms all of it. Must have been stunned.
Absolutely. So Bell turns to his students and explains. He picked up her Fife accent. Burnt Island is the main ferry port from Fife to that part of Edinburgh.
Makes sense.
Then he noticed red clay on the edges of her shoes. The only place nearby with that specific clay was the Botanical Gardens, right next to Inverleith Row. So that must have been her route.
Okay, clever observation. What about the factory?
Two things. First, the coat she was carrying was too big for the child with her. He inferred she must have started her journey with 2 children and left one somewhere along the way, perhaps with relatives on Inverleith Row.
Wow.
And the clincher. She had a specific type of skin inflammation, a dermatitis, on her right hand that was commonly seen in workers at the linoleum factory back in Burnt Island.
That's just putting it all together. It's pure deduction from tiny details.
Exactly. It's the synthesis of observation, the absolute peak of clinical reasoning based on physical examination.
But that kind of incredibly detailed, time-consuming analysis, that feels like exactly what's been lost in modern medicine. Harrison's points to the 1970s as the turning point.
Yes. That's when the rise of diagnostic technology imaging, lab tests, really started to accelerate. And as those became more prominent, the emphasis on and the skill in bedside diagnosis began to decline.
And it becomes a cycle, right, if it's not taught or tested effectively.
Precisely. It's the old saying in education, assessment drives learning. If training focuses heavily on multiple choice tests or simulations and less on directly observing trainees, examine actual patients and providing feedback on technique,
then the incentive to really master those subtle physical skills just isn't there in the same way.
it naturally diminishes.
So, okay, we accept that technology is fast, it seems objective, it's reproducible. Why fight for the physical exam? Why spend time tapping on a chest when you can just order a CT scan, especially when resources are tight?
That's the crux of it. And the answer, according to Harrison's, is that the PE isn't just a nice historical skill. It remains fundamentally necessary for good medical practice. We need to dig into these 5 pillars they lay out, these evidence-based arguments for its relevance.
All right, pillar 1. This one seems pretty definitive. For a whole range of important conditions, the physical exam findings are the gold standard. There's no lab test, no image that can replace them.
That's right. The diagnosis actually rests on the clinical criteria derived from the exam. It often surprises people, I think, who assume every definitive diagnosis needs, a high-tech test or a biopsy result.
Give us some examples. Where is the PE absolutely king?
Neurology is a prime area. Think about Parkinson's disease. Sure, you might do imaging to rule out a stroke or a tumor, but the actual diagnosis of Parkinson's, that comes down to the clinical features.
Which are?
The classic signs. Tremor, especially resting tremor, bradykinesia, that slowness of movement, rigidity, the stiffness, and crucially the absence of what we call atypical features.
Why is the absence of atypical features so important? What does that tell you?
Because there are other conditions, Parkinsonian syndromes, that can look a bit like Parkinson's but aren't the same disease. They don't respond well to standard Parkinson's treatments like L-DOPA.
What sort of atypical features are we talking about?
Things like falling very early in the disease course, severe problems with blood pressure or bladder control early on, early dementia, or if the motor signs are perfectly symmetrical from the start. If you see those, you start thinking about other diagnoses, maybe multiple system atrophy or progressive supranuclear palsy. The distinction relies entirely on the clinician's observation during the exam.
And the neuro exam does something else scans can't, right? Assessing function.
Exactly. A scan shows you the anatomy. It might show a large area of stroke damage, but only the physical exam tells you how that damage actually affects the patient's function, their ability to walk, talk, use their hands. The anatomical lesion is one thing. The functional deficit is what matters for the patient's life, for rehab, for prognosis.
What about other neurological conditions?
Well, amyotrophic lateral sclerosis, ALS, is another key one. There's no single blood test or scan that says this is ALS. It's a clinical diagnosis made by finding evidence of both upper and lower motor neuron problems simultaneously and ruling out other possibilities.
So careful examination is paramount.
Absolutely. Even for something common like peripheral neuropathy nerve damage in the hands or feet. Often, the diagnosis hinges on the patient's symptoms combined with signs found on exam, like decreased sensation, reduced reflexes, maybe some muscle weakness. Nerve conduction studies, EMG, they're useful adjuncts, but they're often supplemental, sometimes painful, expensive, and ideally guided by findings from a good clinical exam first.
Okay, let's shift gears. Rheumatology. Harrison says blood tests alone often aren't enough.
Definitely not. Having a positive rheumatoid factor or a positive ANA that's anti-nuclear antibody doesn't automatically mean someone has rheumatoid arthritis or lupus.
Why not?
Because these antibodies can be present in healthy people, especially as they get older. They can be false positives. To diagnose rheumatoid arthritis, you need the clinical picture, the pattern of joint involvement, morning stiffness that lasts a decent while, say over 30 minutes, and critically, actually feeling the synovitis, that sort of boggy, spongy swelling in the affected joints.
And Harrison's points out seronegative RA.
Right. Seronegative rheumatoid arthritis. By definition, the antibodies are negative, but the clinical signs and symptoms of inflammatory arthritis are clearly there. If you relied solely on the blood test, you'd completely miss the diagnosis in these patients. The exam is essential.
Okay, cardiology. What about the heart?
Think about pericarditis, inflammation of the sac around the heart. The diagnosis hangs on three things typically: the characteristic chest pain, specific changes on the electrocardiogram, ECG, and hearing a pericardial friction rub with your stethoscope.
And imaging, echocardiograms.
Here's the kicker. The data shows that somewhere between 34 and 50%, maybe even half, of patients with proven pericarditis have a completely normal echocardiogram.
Wow. So if you skip listening for that rub.
You could miss the diagnosis in a huge chunk of patients. The exam finding is critical.
Dermatology and ophthalmology seem obvious areas where observation is key.
Absolutely. Skin conditions like cellulitis, psoriasis, measles, these are largely visual diagnoses. And in ophthalmology, examining the eye is crucial. A doctor needs to recognize the warning signs in a red eye. Things like a ciliary flush near the cornea, severe light sensitivity, photophobia, or vision loss to tell the difference between simple pink eye and something potentially blinding like angle closure glaucoma or a serious corneal infection.
So the takeaway for this first pillar is pretty clear.
It is. For a significant number of diseases, the PE isn't just helpful, it is the diagnosis. Plus, it's safe, it's right there at the bedside, costs nothing extra, and it's invaluable for teaching clinical reasoning and building that essential patient trust.
Okay, but if we're defending the PE in the age of AI and advanced imaging, we need more than just saying it's the gold standard sometimes. We need the numbers, the evidence.
Exactly. And that brings us neatly to Pillar 2, the idea of an evidence-based physical examination. This is about bringing scientific rigor to the bedside.
And it challenges a common misconception among trainees.
Yes. Often there's this idea that evidence-based medicine, EBM, only applies to objective things like lab results or imaging studies. But the late, great clinical epidemiologist Alvin Feinstein really pushed back against that.
What was his argument?
Feinstein argued forcefully that we must apply scientific principles to collecting and interpreting human data too. That means the patient's history, their background, social context, and the physical findings. The PE needs to be more than just rote memorization. It needs to be a tool for applying probability quantitatively.
Okay, but here's the challenge. Maybe the modern pushback. If a sophisticated machine learning algorithm can analyze thousands of data points, heart rate variability, temperature, sleep patterns, whatever, and generate a really precise probability for a disease, why are we still fiddling with tapping chests and using rules of thumb for likelihood ratios? Isn't the algorithm superior?
That's the absolute core of the tension today. And the answer, I think, is multifaceted. First, even the best algorithm needs input data. And the physical exam gathers unique data points, the feel of the skin, the specific quality of a tremor, the resistance in an abdomen, things that require direct human interaction.
Data the sensors can't get.
Not yet, anyway.
Yeah.
Second, and this is maybe more important right now, AI isn't great at generating the context-specific pretest probability.
Context being key.
Absolutely essential. An algorithm might flag a high probability of heart failure based on sensor data, But the clinician knows if they're seeing that patient in primary care, where maybe the baseline chance of heart failure is 14%, or in a specialized heart failure clinic where it's much higher, say 37%, the setting, the patient's story, their environment, that human-gathered context shapes the starting probability in a way algorithms struggle with.
Okay, so context sets the stage. But before we even get to probabilities, we have to address reliability. The classic critique of the PE is that doctors often disagree on findings. One hears a murmur, another doesn't. Isn't that a fundamental flaw?
It's a valid concern, but we need to look at it scientifically.
Yeah.
We measure agreement between observers using something called the kappa statistic, represented by the Greek letter kappa. Kappa tells us how much observers agree beyond what you'd expect just by chance. A kappa of $1 is perfect agreement. 0 is no better than flipping a coin.
And the surprising thing Harrison's points out is
How often high-tech methods also suffer from imperfect agreement? It's quite revealing. For instance, getting radiologists to agree on whether there's an infiltrate like pneumonia on a standard chest X-ray. The agreement is only fair to moderate. Kappa values are around 0.38 to 0.58.
that's not great.
It's not perfect, no. Or look at coronary angiograms, long considered the gold standard for seeing blockages in heart arteries. Agreement among experts on classifying how severe a blockage is only fair. Kappa around 0.33. Even pathologists looking at liver biopsies for cholestasis only show fair agreement, kappa of 0.4.
So disagreement isn't unique to the physical exam. It's a human interpretation problem, whether you're looking at a patient or a screen.
Exactly. The goal isn't impossible perfect agreement, but improving reliability through standardized techniques and training. And when you do that, some physical signs show excellent agreement.
Like what?
Harrison's gives examples. The clock drawing test, often used for dementia screening, has good agreement, kappa 0.73. The abdominojugular test, a bedside maneuver to assess for high pressures in the heart in heart failure, almost perfect agreement, kappa 0.92 when done properly.
But other signs are less reliable.
Yes, things like trying to percuss the exact size of the liver span notoriously have poor agreement. The evidence-based approach means we should probably focus less on those signs, or at least interpret them with caution.
Okay, so we aim for reliable signs. Now, how do we use them quantitatively? You mentioned the likelihood ratio.
Right, the likelihood ratio, or LR. This is really the cornerstone of evidence-based physical diagnosis at the bedside. It gives you a measure of the diagnostic weight of a finding.
How is it calculated? Remind us.
You take the sensitivity of the sign. That's the probability the sign is present if the patient had the disease, and you divide it by 1 minus the specificity. 1 minus specificity is essentially the false positive rate, the probability the sign is present even if the patient doesn't have the disease.
And the LR tells you how much to adjust your thinking.
Precisely. An LR greater than 1.0 increases the probability the patient has the disease. An LR less than 1.0 decreases it. The further away from 1.0, the more powerful the sign.
But doing that math for every sign seems cumbersome at the bedside.
It would be. And that's where the simple rule of thumb, which Stephen McGee and others have popularized, comes in so handy. It makes the LR practical for quick mental calculations.
What's the rule?
LRs of about 2, 5, and 10 roughly increase the probability of the disease by 15%, 30%, and 45%, respectively. And conversely, LRs of 0.5, 0.2, and 0.1 roughly decrease the probability by 15%, 30%, and 45%.
Okay, that seems much more usable. Let's apply it. Harrison's uses the example of hepatopulmonary syndrome, HPS, in someone with liver cirrhosis.
Right. So imagine a patient with known cirrhosis comes in short of breath. Based on their liver disease, let's say your initial estimate, your pre-test probability that they have HPS is about 30%.
Okay, starting at 30%.
Now, you examine them and you notice finger clubbing. We know from studies that clubbing in this context has a likelihood ratio for HPS of about 4.3.
Okay, LR 4.3. Using the rule of thumb, that's close to an LR of 5, which means
It increases the probability by about 30%. So you take your starting 30%, add another 30%, and now your post-test probability jumps to roughly 60%.
just from noticing clubbing, that's a big shift.
Huge shift. But maybe you find something else. Let's say you also notice cyanosis, that bluish tinge to the skin. Cyanosis in this setting has an LR of about 4.4 for HPS, assuming it's independent of the clubbing.
Another LR close to 5, so another 30% increase.
Exactly. So you started at the 30%, clubbing took you to 60%, and now cyanosis takes that 60% and bumps it up by another 30% or so of the remaining probability space.
Yeah.
Pushing the final probability well into the 80% or even 90% range.
Wow. So just by observing those two signs, you've gone from uncertain 30% to highly likely 80–90%.
Precisely. And at that point, you're much more justified in ordering, say, an expensive confirmatory test, like a contrast echocardiogram. The PE findings guided that decision efficiently.
This quantitative approach also tells you which signs are actually worth looking for, doesn't it?
Absolutely critical point. The evidence tells us to focus our effort. We should really only pay attention to signs with large LRs generally, LRs greater than 3.0 or less than 0.3.
Why that range?
Because findings with LRs between 0.3 and 3.0 don't change the probability enough to be clinically useful. They shift it by less than 15% either way, which rarely changes your management plan. They're diagnostically, well, weak.
Let's look at the example Harrison's gives for diagnosing ascites that's fluid in the abdomen in someone who comes in with abdominal swelling.
Okay, this is a common clinical problem. You examine the data for traditional signs. Shifting dullness, a sign many of us were taught, his LR is about 2.3.
So right in that unhelpful zone between 0.3 and 3.0.
Exactly, it barely moves the needle. What does help significantly increase the probability? Finding a fluid wave that has a strong LR of 5.0. And the presence of swelling in the legs, peripheral EBA, has an LR of 3.8.
So those are the rule-in signs to focus on. What about ruling ascites out?
For ruling it out, the most helpful signs are the absence of peripheral edema that has a very useful LR of 0.2 and the absence of dullness in the flanks when percussing, LR of 0.3.
And all the other abdominal signs. Bulging flanks, just generalized distension.
According to the data presented, their LRs fall in that 0.3 to 3.0 range. They're essentially diagnostically unhelpful. So the evidence-based approach tells you, focus on checking for fluid waves, edema, and flank dullness. Skip the rest, they waste time.
Harrison's includes a diagram, sort of a visual ruler, for heart failure signs too, illustrating this.
Yes, it's a great visual. On one side, you have the signs that strongly increase the likelihood of heart failure, the ones with LRs above 3.0.
What's up there?
The most powerful is the abdominojugular test, that maneuver we mentioned earlier, with high reliability. It has an LR of 8.0. Very strong. Also up there are things like a fast heart rate, over 100, feeling the heartbeat displaced laterally, and hearing an S3 gallop, that extra heart sound indicating volume overload.
Okay. And on the other end, the signs that strongly decrease the probability, LRs less than 0.3.
Those include things like a normal response to the Valsalva maneuver, a specific pulse increment during Valsalva, and importantly, a negative abdominojugular test result, which has an LR of 0.3.
What's interesting is what's not at the extremes of that ruler.
Exactly. The absence of an S3 gallop or the absence of a displaced apex beat their LRs are in that middle unhelpful zone. So not hearing an S3 doesn't significantly rule out heart failure. This evidence helps you interpret both positive and negative findings correctly.
Okay, one last piece under this quantitative pillar. Bedside stop rules or risk stratification tools.
Yes, these are incredibly valuable. They use a specific combination of history and physical findings to safely and quickly rule out a serious condition, potentially ending an expensive or invasive workup.
How do they work?
They work because the combined findings have an extremely low negative likelihood ratio, an LR much less than 1.0 for the disease being present, meaning it strongly suggests the disease is absent.
Give us an example.
The Ottawa ankle rules are a classic. If a patient with an ankle injury meets certain clinical criteria, basically, they can bear weight and don't have tenderness in specific bony spots. The LR for ruling out a significant ankle fracture is only 0.1.
LR 0.1 rule of thumb says that decreases probability by 45%.
Right. It makes the chance of a fracture so low that you can confidently skip the x-ray, saving time, cost, and radiation exposure.
What about more acute, serious conditions? Harrison's mentions the Hintz exam for vertigo.
The Hintz battery head impulse, the Stagmus test of skew, is a game changer for patients with acute, persistent vertigo and vomiting. It helps distinguish a benign inner ear problem from a potentially dangerous posterior circulation stroke in the brainstem.
How powerful is it?
If the Hintz exam shows a peripheral pattern, suggesting an inner ear cause, the LR for ruling out a stroke is an incredible 0.02.
0.02, that's tiny.
Astonishingly low. It means a skilled examiner performing the Hintz test can be extremely confident in excluding a stroke, often avoiding the need for urgent, costly MRI scans, and allowing focus on treating the patient's symptoms.
Any other two examples?
The probe-to-bone test in diabetic foot ulcers. If you gently probe the ulcer with a sterile instrument and cannot feel bone, the LR for ruling out underlying osteomyelitis bone infection is about 0.2. Again, very useful for avoiding further investigation like bone scans or biopsies in many cases.
So these rules show the PE, when used statistically, isn't just diagnostic. It's a powerful tool for efficiency and safety.
Exactly. It's about using evidence to be smarter and safer in our workups.
All right, pillar 3. This one shifts focus slightly. It's about the physical exam as a sort of internal screening tool, finding things you weren't necessarily looking for.
That's right. It's about the power of the comprehensive exam to uncover clues to asymptomatic, sometimes serious diseases that are completely unrelated to why the patient came in that day.
These are often things hiding in plain sight.
Often, yes. The kind of findings that, once noticed, can lead to really important preventative interventions. We're talking about things like spotting diffuse enlargement of the thyroid gland, a goiter, which could point to Graves' disease or Hashimoto's.
Or seeing xanthelasma.
Exactly, those yellowish fatty deposits usually around the eyelids. That's an immediate visual clue for high cholesterol, hypercholesterolemia. Or noticing acanthocyst nigricans, the dark, velvety skin patches often on the neck or armpits, which is a strong indicator of insulin resistance, prediabetes, or even underlying malignancy sometimes.
So making these discoveries depends on developing that clinical gaze.
Yes, that conscious, practiced, comprehensive observation. It's not just focusing on the chief complaint, but taking in the whole patient. And Harrison's highlights that the patient's gait, how they walk, is one of the most information-rich, yet often overlooked, sources of clues.
Okay, let's break down the specific gait abnormalities mentioned. There are 3 key ones. First, the coxalgic gait.
Coxalgic gait is usually pretty obvious. It's characterized by this significant lean, a lateral lurch towards the painful hip when the patient puts weight on it. It's fundamentally a pain avoidance strategy. They're shifting their center of gravity off the sore joint.
So pain in the hip joint itself?
Typically, yes. Osteoarthritis, for example.
Okay, second, the Trendelenburg gait. This one's different.
It is, and it's subtler but very important diagnostically. It's also a lean, but the key feature is that the pelvis on the opposite side, the contralateral side, drops down when the patient stands on the affected leg.
And this isn't about pain.
Primarily, no. It's about weakness. Specifically, weakness of the hip abductor muscles, mainly the gluteus medius muscle on the side they're standing on. That muscle normally holds the pelvis level. If it's weak, the other side sags.
What causes that weakness?
Historically, things like polio or problems with hip development. More commonly today, you might see it after certain types of hip surgery, specifically if the gluteus medius muscle or its nerve supply was injured during a lateral approach hip replacement. Recognizing that pelvic drop instantly tells you where the problem likely is that specific muscle group.
And the third gait, circumduction.
Circumduction is when the patient swings their leg out in a semicircle to move it forward, rather than lifting the knee and foot straight up. Often you'll also see reduced arm swing on that same side.
What does that suggest?
It strongly suggests weakness in the muscles that lift the foot and bend the knee, often due to a past stroke hemiplegia. They swing the leg around because they can't clear the foot off the ground effectively otherwise.
So just watching someone walk into the room can give you huge clues about potential neurological or musculoskeletal problems.
Absolutely. And we need to look beyond gait too. The face itself can be incredibly revealing. Harrison's mentions the hatchet face, that distinct facial appearance with wasting of the temporal and facial muscles seen in myotonic dystrophy. That's almost diagnostic on sight.
Or other facial clues.
Noticing small bumps, mucosal neuromas on the lips or tongue, especially if the person also has a tall, thin build, a marfanoid habitus. That combination screams potential in pursuit. Multiple endocrine neoplasia type 2B, or MEN2B, a serious genetic syndrome.
Even skin color changes.
Yes, like the subtle blue-gray discoloration sometimes seen on the face, the imidazole facies. It tells you the patient has likely been on the heart medication imidazole long-term, which is important history that might be missing from their record or they might forget to mention.
The hands, too, you mentioned, are full of information.
A goldmine. While Harrison's cautions that many nail changes named after people, Bow's lines, Terry's nails, Nay's lines, are often nonspecific, other hand findings are incredibly valuable.
Such as?
Osler's nodes, those tender bumps on the fingertips, or Janeway lesions flat, non-tender red spots on the palms or soles. These are classic, though rare, signs of infective endocarditis, a heart valve infection.
What about liver disease clues?
Bright red palms, palmar erythema, or spider angiomas, little red spots with radiating vessels on the upper chest, strongly suggest underlying liver dysfunction.
And neurological signs in the hands.
Things like the specific way someone releases their grip in myotonic dystrophy, myotonic grip, or the inability to lift the wrist, that classic wrist drop indicating radial nerve palsy. These immediately point you towards a specific diagnosis for nerve injury.
Okay, then there's smell. Diagnostic odors. That sounds almost archaic.
It might sound old-fashioned, but olfaction is a powerful, immediate diagnostic sense that no technology can replicate yet. Certain smells are strongly associated with specific conditions, sometimes life-threatening ones.
Give us some examples from Harrison's.
A sweet, almost grape-like odor might suggest a wound infection with Pseudomonas bacteria. A really foul, fetid smell could indicate an anaerobic infection, like a lung abscess.
What about metabolic problems?
The smell of ammonia, sometimes described as mousy or fishy, is characteristic of severe liver failure, hepatic encephalopathy. A urine-like, uriniferous odor points towards kidney failure, uremia. The fruity acetone smell is classic for diabetic ketoacidosis.
And in poisoning cases.
The distinct smell of bitter almonds is a rare but critical clue for cyanide poisoning. Recognizing these odors requires no equipment, takes no time, and can be life-saving by prompting immediate, specific treatment.
Even clothing and body shape.
Yes, simple observations. Is the patient wearing clothes inappropriate for the weather? Wearing way too much might suggest hypothyroidism, feeling cold. Wearing too little could hint at hyperthyroidism, feeling hot.
What about neglected appearance?
Neglect of clothing, hygiene, or even odd color choices can sometimes be early signs of dementia or delirium. And then body shape or stature. Is the person unusually tall and thin? That might prompt you to look for other signs of Marfan syndrome, like a protruding sternum, pectus carinatum, reduced elbow extension, or measuring their arm span versus their height. An arm span significantly greater than height, ratio 1.05, is another clue.
So Pillar 3 is really about the exam forcing you to take that comprehensive, holistic view, looking for clues beyond the immediate problem.
Exactly. It acts as a built-in screening process, resisting the tunnel vision that can happen when you only focus on the chief complaint listed in the chart.
Okay, moving on to Pillar 4. This one feels like the flip side of Pillar 3. It's about what happens when the physical exam is not done well or not done thoroughly. It's about avoiding errors and preventing harm.
Precisely. This pillar makes the critical argument that missing important findings on physical exam is not just unfortunate, it's a direct, quantifiable cause of medical errors. It leads to diagnostic delays, unnecessary tests and radiation, increased morbidity, sometimes even death, and potentially malpractice claims.
The examples Harrison's provides here are quite sobering because they highlight failures that seem preventable.
They really are. Take the example of a patient coming into the ER with a fever. If the clinician doesn't fully undress the patient to examine their skin properly, they could easily miss petechiae, those small, non-blanching red or purple spots or larger bruises, ecchymoses.
And why is that so critical?
Because in a febrile patient, that kind of rash is an immediate red flag for life-threatening infections, like meningococcemia, caused by Neisseria meningitis, or Rocky Mountain spotted fever. Missing those signs means delaying crucial antibiotics, which can have devastating consequences.
What about less acute scenarios, missing subtle signs?
Consider a patient presenting with wrist and ankle pain. They might get an extensive workup for complex autoimmune diseases like lupus or vasculitis. But maybe later someone notices they also have finger clubbing, and maybe subtle signs of Horner's syndrome, like a droopy eyelid and small pupil on one side.
What does that combination suggest?
That combination points away from primary rheumatologic disease and strongly towards something called pulmonary hypertrophic osteoarthropathy. It's often a paraneoplastic syndrome, meaning it's caused by an underlying, often hidden, cancer, usually lung cancer. A thorough initial exam looking beyond just the joints could have picked that up much earlier.
There's also the classic example of chest pain being misattributed.
Ah, yes, the shingles case. Imagine a patient with chest pain severe enough to activate the cardiac cath lab team for a suspected heart attack. They're about to undergo an invasive procedure.
And then someone notices the rash.
Exactly. Someone finally looks closely at the skin and sees the characteristic pattern of vesicles on a red base, following a single dermatome dewdrops on a rose petal. That's herpes zoster, shingles. It can cause severe pain mimicking cardiac pain, but the treatment is antivirals, not cardiac catheterization. A quick look at the skin could prevent unnecessary risk and cost.
This issue seems compounded by what's called diagnostic momentum.
Very much so. Once a label is applied, especially an incorrect one, it tends to stick. Harrison cites data showing that when patients initially diagnosed with cellulitis, a skin infection in the hospital, are later seen by dermatologists, about a third of them actually have something else entirely, maybe eczema or chronic venous changes, lipodermatosclerosis or lymphedema.
So the initial potentially flawed diagnosis wasn't challenged.
Right. Subsequent teams might just accept the initial label without re-examining the patient thoroughly themselves, and the error gets perpetuated.
And this leads to the disturbing situation where radiologists find things that should have been obvious at the bedside.
It's unfortunately common. A patient gets admitted with vague symptoms like abdominal pain or gastroenteritis. Later, a radiologist reads an admission X-ray or CT scan and reports, say, a strangulated loop of bowel caught in a hernia, or air under the skin indicating Fournier's gangrene, a rapidly spreading soft tissue infection. These are surgical emergencies that are often palpable or have visible signs if someone had just looked and felt carefully at the beginning.
So these are errors driven by omitting parts of the exam, but the exam can also correct errors, even errors from technology. The rule of the pupil.
Yes, this is a fantastic example of the PE overriding or clarifying technology. It relates to an acute third cranial nerve palsy where the patient suddenly develops a droopy eyelid and their eye looks down and out. The key physical finding is the state of the pupil on that side.
What's the difference?
A dilated, poorly reactive pupil strongly suggests the nerve is being compressed, usually by an aneurysm, specifically a posterior communicating artery aneurysm. That's a neurosurgical emergency. But if the pupil is normal size and reacts normally, we say the pupil is spared. It strongly suggests the cause is ischemic, due to lack of blood flow, often from diabetes or hypertension, which is generally managed medically and has a good prognosis.
So even if the patient gets an urgent brain scan?
The physical finding of the pupil still guides the interpretation and management. Harrison's gives two powerful case examples. In one, the initial imaging suggested a tumor might be compressing the nerve, but the pupil was spared. The clinicians trusted the physical exam finding, managed the patient for ischemia, and the patient recovered fully without surgery.
In the other case?
The pupil was abnormal, indicating dangerous compression, but the initial CT angiogram scan was read as normal. Because the clinicians stuck to their guns based on the concerning physical exam finding, they pushed for the scan to be reviewed again. And a small but critical aneurysm was found. The physical exam finding literally challenged and corrected the initial negative imaging result, leading to life-saving treatment.
It shows the PE isn't just about finding things, but also about interpreting everything else correctly. So why do these oversights, these incomplete exams, keep happening?
Harrison's points to several factors deeply embedded in modern practice. One is simply that exams are often done too quickly. They're cursory or incomplete. Paradoxically, the electronic medical record, or EMR, can sometimes make this worse.
How so?
Because EMR templates often have pre-filled sections or allow easy copy-pasting from previous notes. It becomes very easy to document a complete physical exam in the chart and bill for it, even if only a very limited exam was actually performed.
And that creates a false record of thoroughness.
Exactly. It can mask the fact that a proper exam wasn't done. Add to that the sheer volume of patients, the pressure for rapid turnover, and frequent handoffs between different doctors or teams.
The continuity is lost.
Yes, and with it, sometimes the sense of personal responsibility to do a fresh, thorough assessment. The physician receiving the handover might rely too heavily on the documented, potentially incomplete or inaccurate information from the previous team, rather than starting fresh with their own eyes and hands. Maintaining clinical skepticism becomes harder.
So Pillar 4 is a stark warning about the consequences of letting this skill erode.
It really is. It's a call for diligence, thoroughness, and recognizing that skipping or rushing the exam isn't just inefficient, it can be actively harmful.
Okay, we've arrived at the fifth and final pillar. This one feels maybe more philosophical. It's about the physical exam as a sacred ritual. What does Harrison's mean by that?
It means looking beyond the purely diagnostic function and recognizing the profound psychological and, you could say, anthropological role the examination plays in the healing process and the doctor-patient relationship.
Awesome.
Well, think about the encounter from the patient's perspective. For the doctor, seeing many patients might make the interaction feel routine. But for the patient, it's often anything but. It's an act of significant vulnerability.
They're sharing private information, often feeling unwell.
Exactly. They're revealing sensitive details, often dressed in a hospital gown, which Harrison's notes is itself a marker of dependency, while the physician is often in a white coat, described sometimes as almost a shamanistic garment, signifying authority and knowledge.
And then comes the exam itself.
Yes. One person, the patient, allows another person, the physician, often a relative stranger, to touch them, manipulate their body, look into openings, maybe probe sensitive areas. In almost any other social context, these actions would be completely inappropriate, possibly even considered assault.
It highlights the trust involved.
Immense trust. The act of allowing the physical examination signifies the patient accepting a kind of contract and agreement to be cared for, and placing trust in the physician's professional role and intent.
And Aristotle draws parallels to formal rituals.
Yes, looking at it through an anthropological lens, the encounter has hallmarks of a ritual. Think about what defines rituals across cultures.
There's usually a crossing of the threshold.
Right. Entering the exam room, changing clothes. There's a commitment involved, the patient's commitment of trust, the physician's commitment to care. And there's a sense of transformation. The patient moves from being self-sufficient to actively seeking help and intervention. The exam itself validates their symptoms, grounding the illness experience in their physical body, their soma.
Okay, but let's play devil's advocate. In a busy ER or a packed clinic schedule where time is incredibly tight, is thinking about a sacred ritual realistic? Isn't it just a series of checks you have to get through? Does the pressure for speed and efficiency completely undermine this idea?
That's the danger, and Harrison's argue strongly that viewing it merely as a checklist and sacrificing the ritualistic quality for speed is actually a false economy, because patients notice.
They notice the quality of the exam.
Absolutely. They perceive competence, care, and respect, or the lack thereof. They can judge the skill and the manner of the examination, maybe subconsciously, much like you judge the skill of a craftsman or a chef.
So a rushed, clumsy exam is obvious.
Definitely. Slapping a cold stethoscope on top of clothing, a quick impersonal poke at the abdomen, skipping parts of the exam altogether, patients pick up on that perfunctory approach. And that perception damages trust, which can undermine everything else that follows, like adherence to treatment or overall satisfaction.
There's a quote from Sir William Osler in the text about this.
Yes, Osler, one of the giants of medicine, emphasized this. He said something like, "Skill and nicety in manipulation will do more towards establishing confidence in you than a string of learning and Latin quotations." The act of examining well is therapeutic in itself.
And this connects to the psychobiological effects, the idea of a placebo without a placebo.
Exactly. We know from research on the placebo effect that the context of care, the setting, the interaction, the clinician's empathy and confidence, the ritual itself can trigger real, measurable physiological changes in the patient.
Oh.
It's thought to involve pathways related to expectation and conditioning, potentially releasing the body's own pain relievers, endogenous opioids, or other neurotransmitters. A thorough, respectful, attentive physical exam fulfills the patient's expectation of being cared for, tapping into this powerful therapeutic potential. It leverages the positive meaning of the encounter.
And the flip side, a bad exam experience.
A clumsy, indifferent, or rushed exam can have the opposite effect, a negative or nocebo effect. It can generate anxiety, distrust, and dissatisfaction, potentially making symptoms feel worse or making the patient less likely to trust the diagnosis or follow the treatment plan even before it's fully explained. So the quality of the exam ritual has real biological and psychological consequences.
And finally, this pillar touches on how these skills are passed on or lost.
Yes. Harrison's highlights the concern about the decline of traditional bedside teaching rounds in hospitals. When teaching shifts primarily to conference rooms, looking at data on screens rather than examining patients together at the bedside,
The transmission of the skill is broken.
it becomes much harder. Learning physical examination skills requires seeing experienced clinicians demonstrate them repeatedly, getting direct, hands-on practice, and receiving immediate specific feedback on your own technique with real patients. It's an apprenticeship model in a way. When that mentorship becomes virtual or abstract, the practical skills inevitably atrophy over time.
So the ritual isn't just for the patient, it's crucial for training the next generation too.
Absolutely. It ensures that physicians remain grounded in the reality of the patient as a whole person, an embodied individual, not just an interesting case or a set of data points on a screen. #tag3, recent updates, evidence summary.
Okay, so if we pull all that together, the core message seems to be that the modern defense of the physical exam isn't just about clinging to tradition, it's about recognizing its evolution into an evidence-based science.
I think that's exactly right. The really big intellectual shift highlighted in this section of Harrison's is moving beyond just thinking about sensitivity and specificity, which are important concepts, but often hard to apply directly in the clinic, and really embracing the likelihood ratio, the LR, as the practical go-to tool at the bedside.
Because the LR gives you that immediate sense of diagnostic weight.
Yes, it tells you how much a specific finding should shift your suspicion up or down.
And critically, using LRs lets us be more efficient, right, by focusing our attention.
Precisely. It allows us, based on evidence, to essentially ignore the findings that fall in that statistically weak middle ground, those LRs, roughly between 0.3 and 3.0, because they don't change the probability enough to matter clinically. We can then concentrate our limited time and effort on looking for the few powerful signs that do significantly increase or decrease the likelihood of a disease.
We saw that clearly with the hepatopulmonary syndrome example. Just 2 findings, clubbing and cyanosis, with LRs around 4.3 and 4.4.
Could take you from a starting probability of 30% to over 80%, based purely on observation. That's the power of using LRs quantitatively to guide your thinking and justify subsequent, maybe more invasive or expensive, testing.
And this quantitative rigor also underpins the STOP rules.
Yes, those evidence-based protocols that provide a crucial safety net in busy environments. Things like the Ottawa ankle rules or the HINTS exam for vertigo. Their power comes from having extremely low negative likelihood ratios, often 0.1 or even 0.02.
Meaning if the rule criteria are met, the chance of the serious condition is so low you can stop the workup.
Exactly. You can safely and confidently decide not to order the X-ray or the MRI, saving resources and avoiding potential harm from over-investigation, all while maintaining a very high degree of patient safety based on solid evidence.
But all this data, all the LRs and rules, they're only useful if someone actually performs the exam skillfully and thoughtfully. The human element remains central.
Absolutely non-negotiable. The concern about the erosion of bedside teaching, the replacement of hands-on learning with screen-based analysis, is a serious threat to maintaining these skills. The mentorship, the role modeling, the practice, the ritual itself. These are essential for transmitting the art and science of the physical exam to future doctors.
So the physical exam isn't just about the findings themselves, but about the entire process.
It's the unique ability of the physician to integrate everything, the history, the social context, the physical signs using scientific rigor, but always within the context of that individual human being sitting in front of them. That's what truly personalized care requires. #4. Summary and final thought.
So this deep dive into Harrison's really drives home the point that while technology is an incredible asset, it's not a replacement for core clinical skills.
No.
Let's quickly recap those 5 pillars supporting the physical exam's value.
First, the PE is still the diagnostic gold standard for a surprising number of important conditions. Think Parkinson's, seronegative RA, where technology simply can't provide the definitive answer.
Second, the modern evidence-based PE uses quantitative tools, especially likelihood ratios, to smartly and rapidly refine probabilities, helping clinicians decide which tests are truly needed next.
Third, a thorough exam serves as an unmatched screen for unsuspected clues. It often reveals vital signs of asymptomatic disease, from gait changes to skin findings to odors, allowing for much earlier intervention.
Fourth, failing to perform the exam well is a significant and quantifiable source of medical error, leading to diagnostic delays, patient harm, and wasted resources, often made worse by workflow issues like poor handoffs or over-reliance on templates.
And fifth, the physical exam acts as a crucial therapeutic ritual. Done with skill and care, it powerfully builds trust, validates the patient's experience, and can even leverage positive psychobiological effects akin to the placebo response.
So the final thought here seems to be about the richness it adds to practice. Mastering the skill of reading the body isn't just technically important.
No, it makes the practice of medicine more intellectually engaging, more rewarding. It inspires trainees. And fundamentally, it reaffirms that medicine, at its heart, requires the physician to connect deeply with the patient as a whole person, not just interact with their data.
That human connection, backed by science, remains the core.
Indeed. It's arguably our most powerful tool, both for diagnosis and for healing.
Thank you for joining us for this deep dive. We hope this exploration encourages everyone to perhaps look a little closer next time.